Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. This is a special edition Beat Breathlessness podcast. Beat Breathlessness is an initiative with Everton in the Community, University of Liverpool, the Pumping Marvellous Foundation, all supported and funded by the British Heart Foundation. Today, we'll be discussing Beat Breathlessness from symptoms to system change, a podcast about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. Do we have options to reduce the time to diagnosis and treatment initiation? Because if we don't innovate, breathlessness will immobilise and paralyse our NHS. Welcome to the Liverpool podcast studios this sunny afternoon in Liverpool, of course. With this podcast, I'd just like to put everything into context. So heart failure affects over 1 million people in the UK. I'll leave that one with you. But in the Merseyside City region of 1.6 million people, that means that up to 32,000 or even more may be living with heart failure. And that's estimated on our current prevalence rates of up to 2%. Mortality exceeds that of many cancers in heart failure. And yet, unlike cancer, early recognition still depends heavily on the knowledge and confidence of primary care. And today we're asking a simple level question. Surely now's the time to invest in doing things differently, considering the increasing prevalence and impact of heart failure and respiratory conditions and the impact on the patients and the NHS in terms of how it's measured across health domains. So let's introduce our guests. Who are we going to start first with? Amy.
Hi, I'm Amy from Everton in the Community. I am our health screening lead.
Welcome, Amy.
I'm Gail Rook. I'm a long-term conditions delivery lead for Cheshire Mersey ICB.
And Rajiv.
Hi everyone, Rajiv Sankaranarayanan. I'm a heart failure cardiologist in Liverpool.
So, Amy, what's the Beat Breathlessness programme?
So the Beat Breathlessness project, which is a bit of a mouthful to say.
Programme?
Program. Breathlessness?
Yeah.
Whole damn thing. So it's the first of its kind community screening hub for heart failure and respiratory conditions. We're able to offer point of care testing for a variety of different cardiovascular conditions, but we are focusing on heart failure as well as all of our blood pressures, atrial fibrillation, and anything else.
Rajiv?
Yeah, so it's preventing, diagnosing and treating. So bringing everything together in a one-stop setting. It is taking the specialists out to the community and it is being proactive. It is going out to the community, asking people, testing people, not leaving it for them to come to a hospital setting when they're very, very unwell, picking up these conditions when they have milder symptoms out in the community.
So we've got 3 hubs, yeah? We've got one in the People's Place, which is a sort of the north hub. And then we've got one in Central, London Road, I think it is. Yeah. And then we've got one with the Swagger PCN in South Liverpool. What pathways are they? Why is this different? What makes the pathway different? What makes
so it's about so you'll know the BEAT acronym, which obviously Pumping Marvellous created many years back, but it's about extending and taking it out into the public space and implementing it. So we want to sort of spread the awareness. If you're breathless, if you're exhausted, if you have ankle swelling, it's time to reach out to a clinician, or the clinician to reach out to you and pick up these symptoms. So it's about using BEAT in that way, but using it to diagnose a condition which can be quite complex, breathlessness. There could be multiple causes for that. The heart and the lungs are the predominant 2 causes. So when you're talking about BEAT breathlessness, like Amy was saying, you're also picking up conditions like atrial fibrillation, the irregular heartbeat, which can give breathlessness. You're picking up undiagnosed, untreated high blood pressure, which can lead to these conditions, heart, lung and stroke conditions, ultimately if people have high blood pressure. So it's about bringing all of that together in a simple, easy to implement pathway. And that's what we created. So myself and a chest physician, when we created this pathway, we wanted to make sure that it's something that can be implemented easily on a day-to-day basis.
So we're just gluing it together differently.
Yeah.
For speed of recognition, speed of diagnosis, and speed of treatment.
Yeah, but not at the cost of cutting any corners. We're still making sure that the specialists make the diagnosis, and we use all the investigations that we would have otherwise used in a standard of care pathway. But we add in simple, easy to implement in the community tests, point of care tests, using AI in an intelligent way.
So the challenge is certainly from a heart failure perspective for diagnosing, when you don't have an Everton in the community model, a BEAT Breathlessness hub, is that it could take months, if not years, to recognise people with the symptoms of heart failure, which we know is the BEAT acronym. But it's not just that, it's actually getting that simple blood test to check whether it could be or isn't heart failure, which is very easy to do. And that could be, months until that's administered. And then from there, we are waiting maybe months, dare I say 12 months, over a year maybe, which is quite difficult to comprehend for a heart scan, for an echocardiogram. And then you've got to, because there's so many patients involved and people involved in that pathway, you have to wait for the consultant cardiologist or somebody who's qualified to make an appropriate diagnosis, interpret those results that have been accumulated over time. And then they've got to get treatment. What we're saying here is in 60 minutes, in Everton and the community hubs, which there are 3 in Liverpool, we can do it in 60 minutes.
Yeah.
I mean, that's like a wow moment. It's like take a deep breath. How do they do that? So, Gail, why is it so important?
It's important because it captures people much earlier than the traditional pathway. So, if you're waiting 12 months for someone with heart failure, that could be the difference between life and death. 12 months is a long time. Once you've been diagnosed with heart failure, it's even longer if you've got no diagnosis. So it's really important that we see those people in the community sooner. So that's what this is doing. It's just bringing things forward. And it's really moving us from that reactive business that we have in the NHS to that really proactive, finding these people earlier. And then once you've got that diagnosis, move on with your life. Whereas if you're waiting for 12 months or longer, waiting for the diagnosis, it's hanging over you, you're worried about it. And then, like I said, for some people, they never get to have the actual diagnosis. It's, it's come to the fact that they've perhaps died. And I think that's a real shame, especially when we know we can do things sooner for people.
Did you use the word traditional?
I did. Could
we make this traditional?
Yeah.
Do you think it'll ever get there? Or do you think it'll always be seen as a innovation?
I think we have to get there. I think it's really important that this becomes the norm and that the old pathway becomes the old pathway and not the traditional pathway.
And from a non-healthcare point of view, in other words, you don't work for the NHS like I don't. Why is this important to the people that you see?
I think it's because working in L4, one of the most deprived neighbourhoods in the whole of the UK, we're targeting people who most commonly don't access healthcare, won't go and seek support, won't go and ask questions about symptoms. They might, again, think that they're too busy, or they might think symptoms are down to something else, and then they won't ask for support. But being in the community ourselves, we are providing an opportunity for people might come for different reasons, but then whilst they're there, as Rajiv said, giving them the opportunity to ask them beat questions whilst they're there, and you could pick something up before they've even recognised that something's going on. Or people might feel comfortable coming to you in the first place with symptoms and asking, okay, I've got a few questions about how I'm feeling. Is there any support that I can access? Which we do get people coming to us with a variety of different reasons. And one of them is healthcare concerns.
And the association with Everton Football Club, because you are the charity arm of Everton Football Club, is that it breaks down those barriers of actually my club that I support, man and boy or whatever, for I've been doing it, 56 years. That's,
It's a sense of belonging, isn't it?
But it's like, I trust them.
Yeah, definitely. As we said, power of the badge. It's what people see and feel comfort when they recognise that badge and they know it's a place that they trust.
So, Rajiv, so we hear about it in a microcosm in Liverpool, because, there's other parts of the country. Why would it be important to be scalable and adoptable across the whole of the UK? And that's the four different countries that make up the UK.
I think the one thing we need to do is to take a step back, and that's what we did locally. Take a step back and see that historically what was standard of care was not working. So, like I said, we were waiting for people to get unwell and then come to see us. And do that in a timely fashion, and that was simply not working, and that's why A&Es are always busy. So it's about using. So Everton have been path breakers in many ways in doing this. The People's Place is very unique, community-based hub with that outreach to their supporters. So that's amazing. Obviously, Pumping Marvellous as a charity, you've been doing some very innovative work. Going out and proactively finding people. The BEAT acronym, sort of putting it into a public awareness space. Gail, from the ICB has been a front runner, with long-term conditions. So it's about bringing people, like-minded people. You've used the doubters to believers message before, but bringing the right people together and seeing that we need to innovate, we need to think differently to make the healthcare system work and make it more modern. And that's the important. So once we recognize that, and then demonstrating a workable model, if we can show that. So indeed, the pilot project 2 years back in Everton that we did with the BEAT Breathlessness project, we showed that it works. It's great for patients. It's great for the healthcare system. It saves money.
It's investable.
Exactly. And that's exactly how the British Heart Foundation, when we demonstrated that it's got all these elements coming together, the British Heart Foundation, we're very grateful to, thankfully, gave some money to scale it up. And then scale it up wider, hopefully, where there's no reason Manchester United or a Newcastle or other clubs can't do this, can't replicate this, but also other parts of the country, the ICBs, the Health Innovation Networks, NHS England or whatever that's going to morph into, all of them can come together, which is what we've done locally. So we just need to make it more macroscopic rather than just
So I find this really interesting because we're in a real situation at the moment. What is it, March 26th? There's a huge amount of volatility. So I talk a lot about, a buzzword at the moment is atmosphere. So in the atmosphere, there's a lot of volatility, but around health and how we do things differently. And there's some real fantastic programs and innovation. But actually, the Everton and the Community BEAT Breathlessness hubs are driving this through the storm. And I think it's a really good example of where disruption and opportunity sit well together. And you just go through the nebula and you come out the other end with something absolutely fantastic, and you've dragged everybody with you. So, Gail, you're the person to answer this because you know this. Well, I think you do. Well, I know you do. What's the prevalence of breathlessness across Amy's communities?
It's very common, but it's massively underreported, and that's right through the system. So not just people not coming to report the symptoms, even our GPs maybe not recording it into the system. So when we do a search on data, we don't necessarily know the true numbers of people that are living with breathlessness and heart failure. And that's a real shame because we do a lot of information modelling on prevalence. And so if our prevalence is low, we tend to think that it's not an issue, but in Liverpool particularly, a deprived communities, prevalence is often lower because those people just don't come forward when they've got symptoms, which is it's a real shame, And if we can encourage people to go to community centres and say, actually, I feel a bit breathless, something might be wrong, then that's incredible.
So let's just pick up on we talked about deprivation, okay? And we know the L postcodes are very dynamic, yeah? There's deprivation, then there's some very wealthy areas of Merseyside. It's probably because they've got two of the best teams in the world. Sorry. But you talk about L4 being deprived. How does deprivation amplify delayed diagnoses? What do you think of that?
People that just have more risk factors because of lots of things: poor housing, smoking, environmental factors, occupational exposure. You work in a factory that's producing all kinds of chemicals, so those things contribute to it. And then just the fact that your health is not a priority necessarily when you've got other things happening in your life. If you're
poor
in debt,
quality housing,
your house is poor, there's damp. You don't necessarily know, are you going to feed the kids? Are you putting heating on? To have to make those sort of decisions.
Terrible decisions. Yeah,
health is just something else that you'll deal with another time. It's not important right now. And especially if you have got something and actually you're going and you're picking up your medications, everything's fine. But really what you need to do is you need to be going to get those annual reviews, making sure that things are continuing on that fine trajectory. And actually when something doesn't feel right, knowing that you can go somewhere safe to kind of tell somebody about that issue. People don't want to turn up a hospital because they might have had a relative that's had a terrible time there, but actually they'll pop to the people's place because our football club has said, come along, we're having a bit of a day where you can find out more. People tend to do that. They feel that it's more important because the football club has told them, come along and do this, than sort of the things that they're just dealing with in everyday life.
So how does Beat Breathlessness, Amy, how does your project, how does it cut through to trying to flatten that deprivation challenge?
I think the main thing is providing the opportunity. Again, we're just in the heart of the community. Obviously, when the new stadium was built, a big question was, what's going to happen to the charity? You're going to move location. But no, because that's not where the need is. The need isn't on the dock. It's in the middle of L4, essentially, in that wider area. So us just having that flagship space, the People's Place, the mental health and wellbeing building, offers a unique opportunity in that it can provide a wider opportunities in that centre. So it's not just there for health, it's there for wellbeing. So then just being in the heart of the community where people are familiar with, or across the road from Goodison, it's somewhere that they feel comfortable. And then again, they might not be attending for health screening, they might be attending for other reasons, and something that we can pick up along the way.
Maybe attending because they've never been in an environment that Everton owns, yeah?
Yeah.
I was just about to say, areas of deprivation, which Gail touched upon. So it's all those things, plus, and it's across the country. What we know is people who live in areas of deprivation, they don't have enough GPs to see. The number of GP surgeries are lower than they should be. So that, again, the access to healthcare in a prompt, timely fashion, that's lacking in those areas as well. And this probably helps bridge that gap in a timely fashion, maybe.
I think another thing as well in terms of accessibility is health literacy.
Yeah.
We often don't really think about the people in that area might not be familiar with terms around heart failure, knowing the differences between different heart conditions, and just medical knowledge in general. It can be fairly low, and people to be able to recognise those symptoms and be able to match it in terms of knowing what's going on for them, but then having that awareness to go and get support from someone that they trust.
I think it's important as well when we catch people doing everything. We talk about making every contact counts. And I think, you might have come in to, pick up something, or you've come to see a community project, and actually Amy might be there and say, notice you're a bit breathless. Can I ask you a few questions? I think that's important because people don't always think, I'm breathless, I'm not well. They think, I need to go and sign up for this class, or I need to go and get something from the one-stop shop. And actually, if someone just asks you that question, it's enough to make you go, actually, I have been a bit breathless, and my feet have been a bit swollen.
That's exactly what happened. We've got a chronic pain peer support group, and I just went in just to ask them the beat questions. And there was a lady that said, I've been noticing I walk here every time we have the session, and I'm becoming more and more breathless. But I think it's because I'm not doing any exercise anymore, because she's got a chronic pain condition. So again, associating that deconditioning with the breathlessness rather than assuming it might be something else. So then I've got, of course, that's the time to ask those questions.
It's like a light bulb moment, isn't it? Yeah.
It's like the next time they walk up the steps at Hill Dickinson or Anfield, it's not just the steps, it might be something else.
You're getting ejected from this. But that's a light bulb moment for the patient or person. But it's also a light bulb moment for us as well.
Yeah.
Why is there association? How can we help with that association of breathlessness type symptoms with everyday life? That this isn't normal. Because we talk about normalising.
Definitely.
So what are we learning? Okay, right, put your vision head on, but what are we learning that the system doesn't already know? So at the end of the project, what help with that question?
I think just the true meaning of partnership. I think, the NHS has always been very good at working in partnership, but I think to really work in partnership has kind of got to have some...
It is quite dominant, isn't it, the NHS?
Yeah, we've just got to have some...
everybody wants sort of brand association with the NHS, really, or badge association, let's say.
Yeah, and sometimes I think that's probably the worst thing, is to clinicalise everything. Mental health things happen in buildings that don't have NHS signs on, even though it's all mental health led. It's important to people that they're not going there for NHS care, they're going there because they're doing other things, and I think that's what's important. It's almost like we need to become a silent partner. It's like, the NHS definitely needs to promote all this, but do it silently, let our partners and charities take some of this and kind of persuade people that it's okay to come forward when you've got symptoms.
Yeah.
Amy, could we scale this across different football clubs, do you think? Do you think this is scalable?
Absolutely. I feel like other football clubs, other sport charities have already got that foundation in the community and they're able to set up these things. It's just, again, those partnerships that they might be lacking or not even thought of the idea this is something that we can do. But a lot of them are already in the health space. So it's something that we need to
Are you
build
thinking
on.
about how you create new partners, new believers, new, people interested in doing this? Are you thinking that as a football club?
It's a message that we can definitely share. I feel like, of course, we're really close to other football charity clubs when we go to Premier League
do you all work
conferences.
together, or is it a bit like...
Yeah, we do, absolutely. I feel like there's this, people think we step
Look
on
out,
each
the
other's
gooners are coming
toes.
through
Yeah, yeah. But it's definitely about working together, especially when there is multiple clubs in the same city. Doesn't mean that we can't work together for the same goals. Essentially,
But
you want to help the same
take this
population.
to Leeds United, or do you think you can do a presentation to West Ham or Portsmouth or Cardiff?
Absolutely. Why not?
Well, I think that is, why not?
Why not?
Yeah.
And this is what we were just talking about before, where, here's a weird one. So people do stuff to work within the NHS. Why don't we get the NHS to work with us?
Yeah,
So change the dynamic.
definitely. And just being an example, isn't it? And showing how it's done.
Sort of breaks those barriers. I was telling you, the traditional barriers where people only work in certain settings. It's like, football's not just played in your fancy Hill Dickinson, it's played on the streets.
Yeah.
And that's exactly what we take everything out of the community, including the NHS. NHS should not just be based in a big building in a secondary care, tertiary care setting. It should be more out in the primary care, and that's where the funding should go to as well. And that's where the specialists should go to as well.
So here's a big question, really big question. How do you take what Amy's doing and scale it in the NHS?
Just need more Amy's and Gails to sort of replicate and
You have to just share the good news, don't you? The kind of the outcomes that we see. If we're saving lives, if we're making things happen quicker, why wouldn't other places want to do that?
and the people who hold the
no-brainer.
purse strings should see. Like the BHF has done. It can't just be the
what a
charities.
leadership position, the British Heart Foundation.
Yeah, but it can't just be the charities funding this. It should be the NHS at scale. Whoever holds the purse strings or the money, they should fund this and see the value in this. Because if you're seeing charities doing this, obviously the Pumping Marvellous Foundation is a big is a heart failure charity of the UK. You have the British Heart Foundation. You've got Everton in the community who are a charity as well.
Yeah.
We can't just rely on charitable funding for this. You need the system to see the value to fund this and make this normal life really in the NHS.
So here's a bigger question. So let's say you want to scale it in the NHS. How do you make it scalable in the NHS versus the local adaptations that Gail and Amy and yourself are doing? How there's got to be a challenge there, because you ain't got no soggy bottoms, have you? You're perfect, but you got the right cake.
No, the simplicity in this is it's not about adding. We don't need more staff or new staff. You need staff to work differently and in different settings. So again, it goes back to the traditional way that where the staff are regimental and where they work and they only work in the hospital, for example. No, if staff can work across these boundaries, out in the community, go out and see these people before they get critically unwell and come out into the hospital setting, we'd love that, isn't it? Picking them up a little bit earlier and treating them. Because once you've seen them in a hospital setting, they're a lot more unwell and it's very difficult to cure the condition or manage it. It's a lot easier if you see them when they have milder symptoms, for example. So it's about recognizing that. So we're not asking for more staff necessarily or more money. It's just about working wisely. It's like your gegenpress, your tiki-taka, your total football. It's about having a rethink of how the NHS is.
Okay, Gail, what should the NHS expect to see? The NHS, not Liverpool.
Yeah.
What should the NHS expect to see if this works?
Well,
It's not if it works, when it works.
When it works, the shift, isn't it? It's the shift from reactive care to proactive care, and that's where we need to get to. Public health colleagues tell us it's all about primordial prevention, which is before you even have hypertension, before you even have risk factors. It's about kind of getting really upstream. But that's a big cultural shift and is going to take some time. But I think projects like this can start to raise the flag a little bit for that, to say this is how it can work. This is how you move to prevention. This is how you stop people from turning up. I don't want my patients coming to see Rajiv. I want to see them out in the community before they even get to that point. And actually, in an ideal world, people just don't get heart failure anymore because they're eating well, they're exercising, people are stopping smoking, drinking less. They're all the things that we need to achieve. But, if you think about it like a barge in the Mersey, it's not going to turn around in one day. It takes time to do that. But I think we are moving in the right direction. The 10-year forward plan tells us that this is the shift that we need to start to recognise now. And I think that we are doing that in the NHS.
And that's exactly what you said, the 10-year plan, the elements. Yeah. This gives you the perfect example of how you implement it, isn't it? So you have the moving to the community from the hospital, prevention, going away from treatment to just preventing these conditions, but also the digital element. We are in implementing what I wouldn't call it AI, it's real intelligence into all of these things, isn't it? Yeah. Getting the digital elements into it. So it's given you a perfect mechanism of how to implement the 3 core components of the 10-year plan.
Yeah.
So what decisions do we need to make?
So, hopefully the reach from this podcast, it reaches not just people, in terms of spreading awareness. And
do you think people will view this internationally and say, yeah, this is a great idea?
Yeah, already, you'll know this. We were invited to present in Washington, isn't it? Where a lot of people saw value and saw how this could easily be implemented in the US using your basketball, your baseball, so different sports, for example. Yeah. So it is that recognizing the value, not just internationally, but in the UK. I think it's very, very important, seeing the simplicity and how this can be implemented and what the benefits are. So hope this reaches not just the people, the public, but also the commissioners. The councils, everyone who can sort of influence genuine positive change.
Okay.
Yeah, I absolutely agree. I think that's what we have to aim for. And I think it'd be really great if other places, even wider than the NHS, took up. It's almost like they've got the question, we've got the answer. So why are they not coming to us for the answer we can share with them?
We want to give this to people, don't we?
Yeah.
We don't want to say this is our idea, really. We want to gift it to people and just give it to people to help people. That nicely moves on to the last question, which I'm going to ask Amy, because I think she's perfectly positioned to describe this. But how would patients experience care differently?
I think patients experience care in the community in what we were explaining before about a trusted space. It's a place that they go and it's where they can access multiple avenues of support. So it's not something that they might go just for healthcare. They're not seen as a patient, they're seen as a person. So it's treating them as an individual that lives in an environment that impacts their health and well-being, and being able to ask those questions, making every contact count. And this is exactly what this project does. It's making every contact count and asking those big questions for anyone who's experiencing any of them and giving them that care essentially in the community.
So it's the last bit for you. All right.
Yeah.
Give some food to thought for people who are listening to this podcast, wherever they are in the world. Just tell them what you want them to think about.
Think about the people. That's all it is. Think about the community and how many lives could be affected by it. It's not just about, we were saying, primary prevention, it's secondary prevention, picking up those people who need it most. And essentially you want to do them a service.
Well, a super powerful podcast from a great team who really understands the project. And yet again, thanks to the partners and the British Heart Foundation for funding and having belief in something that could have a paradigm effect, certainly in breathlessness going forward. Thank you.
Thank you.